On behalf of the University of Iowa Hospitals and Clinics, we thank you for attending today's presentation on pediatric brain and spine tumors with Dr. Markio Sato. Our faculty's goal is to share information you can use about the latest therapies and techniques in medicine and answer your questions about how to partner with us in the care of your patients. These are informational presentations to enhance your clinical practices and to provide you the most updated information we have. No CME credit is provided at this time. This program is being recorded and will be posted to our educational resources page for referring physicians. We encourage questions throughout the program using the chat function, or at the end, you can also unmute yourself so you can interact with Dr. Sato. At this time, I'd like to introduce Dr. Markio Sato. She's a clinical associate professor, neuro-oncologist, and in the pediatric hematology oncology. So Dr. Sato, thank you for joining us, and I'll turn it over to you.
All right. Thank you, everyone. Can you guys hear me okay?
Yep, we can hear you.
Okay, good. So thanks for this opportunity, and thank you for your time to join me. It is really a privilege to talk to you guys because you guys are the ones to find our patients. So we were definitely like to hear from you, like how we should also respond to you as well. So, okay, so maybe here. Okay, I have no financial conflict. So I would like to talk to you today about pediatric brain tumor is different from adult brain tumors in many reasons. And then I will touch with epidemiology quickly, and then risk factors and inheritable disease in brain tumors. And I would like to use a lot of time to talk about the location of the tumors, which dictate the symptoms of the brain and spine tumors. And then I added a couple of cases of common brain tumor types, and then touches a little bit of how we treat and outcomes. And then lastly, I would like to mention about the emergency cases in my tumor groups. So pediatric brain tumors occurs about 3.3 to 4.5 cases per million person years. And this is only 1/10 of adult brain tumors. Adult brain tumors are mostly glioblastoma and meningioma, which you probably hear more about it. But pediatrics, for example, meningioma is very rare, and glioblastoma is small percentage of the pediatric brain tumors. So we have a whole lot of different types of adult brain tumors, and then we treat differently, of course, because patients are from infant or newborn to the almost adolescent or adult patients. Just to compare, the breast cancer is one of the most common women's cancer, and then those are about 100 cases per million incidence. So this kind of dictates that our funding limitations, that not so many cases, and then many different types of brain tumors, because this is breast cancer is just one cancer type of the cancer, but our pediatric brain tumor have many different cases. So that limits our funding for researches and then opportunity to treat. And then I have to emphasize that brain tumors are the leading cause of cancer-related death in children. Most common tumors are astrocytomas or gliomas, you might hear, and those are about 40% of the cases. And they are histologically benign tumors, and then they are, their outcome is good. And then I'm gonna talk to one case about neurofibromatosis, which is the most common genetic syndrome in human. And then 15 to 20% of these patients develop brain tumors. So surveillance is necessary for this population of the patients. So CNS tumors are currently classified on the basis of both histological features and then its presumed site of origin in the tumors in the brain. However, we have new insights into the genomics, and then this dramatically changing the classification, and then also started to have a new treatment strategies. So this data is from 2014, but not much changed. This is the cancer diagnosis of children. Ages are divided by 0 to 14 to 15 to 19. And then as you can see, most common cancer is acute lymphoblastic leukemia, and the brain and CNS tumors follows that, about 20% of the cases. In adolescents, there is most common one is Hodgkin lymphoma, followed by thyroid carcinoma, and brain tumors are the third common tumors. So there are 3 risk factors commonly known in developing brain tumors. First is sex. Actually, boys are more commonly affected by growth, and especially medulloblastoma and ependymoma. So these are the 2 most common malignant cancer, and then that affected boys more than the girls. So that affect the statistics of outcomes, so that the boys die more than the girls because of these 2 diseases. And then second is radiation. We use we use radiation for the brain tumor treatment. However, it's well known that radiation could cause a cancer or brain tumors as well. This data came from the children treated for tinea capitis. They developed the high falls of increased brain tumors. And also the leukemia patient who received total body irradiation for the bone marrow transplant prep regimens, they developed the cancer. And then previously treated for brain tumor patient developed later secondary malignancy brain tumors. So commonly secondary malignant brain tumors are meningioma and glioblastoma. And then so it can happen about more than 6 to 10 years after the first radiation exposures. So it takes quite a lot of time, but it is going to be a big problems in pediatric field because they live longer. And then lastly, there is a known genetic disorders that cause brain tumors. So these are the major ones. So everybody probably knows retinoblastoma and RB1 genes. This is a tumor suppressor genes. And so it can contribute to many different kinds of tumors other than the retinoblastoma. And then main one is pineoblastoma, and it can contribute to glioma or meningioma. Lee-Fraumeni syndromes is genetic abnormalities of P53. This is also tumor suppressor genes, and this contribute to many different cancers, which is breast cancers, osteosarcomas, rhabdomyosarcomas, as well as glioblastomas or other brain tumors. Neurofibromatosis 1, I touched briefly. The most common tumor is optic pathway gliomas, and that affects vision, and that can happen up to 8 years of age. So we have a clear surveillance guidelines for NF1 patient. Pediatrician probably have a couple of NF1 patient who needs a surveillance. Neurofibromatosis 2 doesn't come with skin lesions, so it's hard to find. So they can be, brain tumor can be the first signs of revealing the NF2 patient. So most common ones is acoustic schwannomas. So hearing loss in pediatrics populations needs to definitely be evaluated. And then meningioma, I mentioned the meningioma is rare, but when I see meningioma, always we surveillance the NF2. Turcotte syndrome is contributed to small percentage of medulloblastoma, and then tuberous sclerosis can cause a specific tumor. It's called subependymal giant cell astrocytoma. This is a benign tumor, but we need to monitor, and it can cause the seizures. Gorlin syndrome is another syndrome that contributes to small percentage of medullo, and then von Hippel-Lindau disease with hemangioblastomas. So there is one more inherited disorders that is called atypical teratoid rhabdoid tumor. This is very small percentage of brain tumor, but one of the most aggressive tumors. And then this is the only brain tumors that we know that causative genes. So this is a SMARCB1 is a cancer oncogenes, and then that is mutated. So this is, for example, of histology. So these blue cells are actually the tumor cells, and then these immunostain positive cells are supportive tissues or vessels. So this tumor populations lacks this SMARCB1 positivities. So lack of these genes causes cancer. This requires pretty high intensive treatment with radiations, and then about 35% of ATRT patient carries germline mutations, which can contribute to the kidney cancers and heart cancers of the rhabdoid type cancers. So I'm switching gear to the location of the brain tumors in children. And in general, infratentorial is slightly common. I shouldn't say more common. It's above a little above 50%, including the brainstem regions. So when you see these pie graphs, there is a cerebrum right here and then brainstem right here. The next common location is pituitary. And then I want you to see this spinal cord regions. The spinal cord tumors are small, but there are specific symptoms that we need to look for this. If younger age group or adolescents, supratentorial tumor can be more common because of the adolescent patients have a lot more pituitary tumors and then germ cell tumors. And then specific location for pediatric brain tumors are optic pathway tumors. So this is benign. This never be actually malignant, but it will affect the visions and other regions depending on where the optic pathway is. And then this definitely, this ones we don't biopsy. This is one of the two kinds that we don't necessarily biopsy the tumor, and then we start treatment based on the history and the MRIs. Other common area is the supracellular and the central or pituitary, above the pituitary area. This is challenging because we cannot get the gross total resections. So the symptoms are caused by these specific reasons. So the most common one is mass effect. So this causes intracranial pressure increase. So that's the most common symptoms of headache, nausea, vomiting, and blurred visions. And then if they are younger and then anterior fontanelle was not closed, increased head circumference is could happen. And then if herniation progressed, then altered mental status, that can be just more fatigued or sleepiness or more severe coma status as well. The focal symptoms can happen in certain areas of the brain, mostly the supratentorial regions, causing seizure or memory problems, or if its tumor is frontal lobe, behavioral changes can happen too. And then other location-specific symptoms are cranial nerve deficit from brainstem regions, and then visions from both posterior fossa and supratentorial regions. Exophthalmos ptosis strabismus can happen. And then also, I wanted to bring this up, the tilting of the head. So that is caused by the cranial nerve deficit, which they cannot focus on. They're seeing basically double vision. So they're tilting the head to adjust their visions. So if this tilt is not congenital, definitely this patient needs evaluations. And then uniquely, because kids are developing, so different from adults, so the developmental regression can be a sign of brain tumors. So this is a pretty good articles from Lancet Oncology in 2007 that describes whole different symptoms from different locations. That makes it difficult to diagnose CNS, but I'm gonna go by this one by one. So one of the most common location is posterior fossa tumors that can come in here. And it's actually we see mostly 4 posterior fossa tumors. The most common one is benign tumor, pilocytic astrocytoma. That's the most common. And we just saw one patient in the hospital. He was discharged yesterday. The second one is medulloblastoma. That's the most common brain cancer, followed by ependymoma, and then very rarely ATRT. So I'm teaching only these 4 diseases to our trainees to look for it if posterior fossa tumors. So they are coming from either cerebellum or fourth ventricles or ependymoma, which is the lining of the ventricles. And then their symptoms are usually, oops, I'm not sure what's going on, but usually obstruction of fourth ventricles, so increased ICP symptoms, nausea, vomiting, headaches, and then it affects cerebral symptoms, so abnormal gait, coordination difficulties, tripping over, and then often they have papilloedema. Abnormal eye movement, lethargy, and then nausea can be without vomiting, and then headache will be eventually more specific to morning or nighttime headache. So patients are often feeling well after vomiting because the pressure changes. Macrocephaly can happen, and then squint, the eye symptoms are pretty common. And then, let's see. And then head tilt that we talked about. I have seen 4 or 5 patients who had a head tilt with this area, especially ependymoma. So I would like pediatrician to pay attention to those. So the papilloedema is, you guys may be better than me, but this is the mechanisms of papilloedema. I have a privilege to send to ophthalmologist here, and then also neurosurgeons are very good at detecting these as well. So when patients are sedated or calm, you can see in the eyes and then see if there is a suspicions of increased pressures. And I want you to remember that eye is the window of the brain. So this is the only open part that you can actually see what's going on in the brain. So eye doctor's help is very appreciated. So this is a 12 years old girl who came in the headache and nausea, vomiting, to found to have about golf ball size of the mass with enhancing limbs and some of the solid part, and mostly they are described this is a cystic part. And then this is a very common presentation MRI findings of pilocytic astrocytoma. So they are usually inside of the cerebellum, not so much on the ventricles or frontal part. And then this can be a grossly totally resected. And then this patient does not need any adjuvant therapies. So these patients don't have much of the cognitive deficit. I focus on more like a vision effect because of the pressure changes for the prolonged time. So parasitic astrocytoma briefly is the most common brain tumors, and it's benign, slow growing, and found in cerebrum, like this case, and also found in the midline structures. So one of the examples, optic pathway glioma with NF1, and there are also hypothalamic chiasmatic tumors and the brainstem as well. And then though all these regions can be challenging because we cannot get the gross total resection. And if we can't achieve gross total resection, we will treat with either radiation or chemotherapy or both. We usually start with chemotherapy to delay the radiation timing, but a lot of tumor parasitic astrocytomas are actually not great responder to chemotherapy because tumor is slow growing. So not very many mitotic figures in the tumors. It is classified as grade 1. And then, so I mentioned surgery is curative. And then recently we were finding about 60% of parasitic astrocytoma carries the BRAF mutations, which is a BRAF KIAA fusion protein or mutations. And then we have started treating these patients with BRAF inhibitor or others if they are failing, or actually one of the most recent children's oncology group study treat NF1 patient with either optic pathway glioma or low-grade glioma with fast-line therapy with inhibitors. So the treatment will be changing. So this is another patient who came in at 3 years old with a headache, nausea, vomiting, and they usually are prolonged headache, so like 8 weeks or sometimes 4 months or something like that. They're not every day, they're intermittent, they're usually progressively worsening. They're often treated like a cold or other symptoms because they can come in with an instance of a fever as well. Nausea, vomiting can be all day, but often towards the end when we see them, they are more specific to morning time or waking up at night. So this is a midline tumor. It's pretty aggressive. It has a hydrocephalus and then heterogeneous kind of patterns. When we see those round tumors, we consider very aggressive. So they are growing so fast that it pushes everything outside. So this is an example of medulloblastoma. Although the surgeons can get the complete resection on these cases. And then, however, if we do leave the child with just surgery, the more than 50% of the patient deceased. So we added the radiation and chemotherapy. So this is the blue round cell tumors. When we say that, it's basically the nuclei are purple or blue, and then they don't have much of the cytoplasm, so the nuclei are coming together. Sometimes they're forming some rosette. So these are the formations, and then there are a lot of vessels that the tumor vessels are found, and then usually this is not a great magnification, but these like dark ones can be mitotic cells. So this has a high rate of leptomeningeal infiltration, meaning that it's spread. And then also it can go to extraneural spread, which is like bone marrow, liver, lung, and lymph nodes. So this is definitely a cancer, and then we do the staging. So the most newest, this is from 2011 and 2012. Now we actually subtype medulloblastoma to 4 groups: Wnt, sonic, hedgehog, and group 3 and group 4. This is the genomic figure that they are distinct groups. Especially the Wnt group is notable to be very different from other tumors. So for example, Wnt group is shown here, is most commonly seen in about like 6 to 10 years of age, not so much young age, not so much adult age, but this is about 10% of the medulloblastoma, and then their outcome is good. So here, so with the current therapy, 100% lived when we look back the genomics. So we were decreasing the therapy a lot on this group right now. There are other types, and then eventually we're going to have the different treatment in each groups. So that is the most recent progress in the brain tumor field. So treatment needs craniospinal radiation, which is challenging if patients are especially young. So less than 3 years old, we usually don't use radiation, and we give the high-dose chemotherapy with stem cell rescue. And then it definitely needs the chemotherapy. With this, the standard risk 5-year progression-free survivals are 80%. And high risk would be still about 50%. So this is just challenging. And another challenge is with medulloblastoma is that if we don't treat first line therapy, there is no salvage therapy. So progression-free survival and overall survival actually overlaps in this group. But this therapy is challenging. Pretty much everybody have some kind of neurological deficit from the surgery or from repeated vincristine causes peripheral neuropathies. Hearing loss is actually 100%, not complete loss, but the decline, and about 50% of the patient requiring the hearing aids. Endocrinopathy is common too, based on the ages, but growth hormone effect is about 80% incidence, and the thyroid hormone is about 60% incidence with this therapy. The secondary malignancy rate is currently about 4 to 6% of this patient treated with radiation. And as age is older, we know that the incidence increases. So we have more and more secondary malignancy data coming out. And then most importantly, this cranial radiation can affect cognitive deficit. So even though lower rate for the good kind of medulloblastoma with good resection, we have a data that the IQ will be declining until the adolescent ages steadily. So it may be above average, but it is definitely declining. So this is the field that we need more focused treatment and then different types of therapy, including targeted therapy, to reduce that current toxicity of the treatment. So I'm going to move to the brainstem tumors. These are more commonly cranial nerves and gait and coordination difficulties, sometimes headache, and then pyramidal signs, which is a kind of hyperreflex or the slowing the alternating fast movement. Squint and focal motor weakness can happen based on the brainstem involvement. And then facial pulses, actually cranial nerve pulses, papilledema, and others. We've seen new incidents of ADHD, but I'm not sure how that affects. So this is an example of CT and MRI scans that is a diffuse intrinsic pontine glioma case. So this is a diffusely involved in the pons majorly, but it can go up to midbrain or medulla, or actually go well high above of thalamus. So this is one of the disease in pediatrics that we don't know how to treat yet. So this is a universally fatal disease. The average lifespan is about 6 months to 12 months. Only radiation is the measure that can prolong life, but that becomes 12 to 18 month outcomes. So none of them can be cured yet. So this group of the patients are newly categorized to diffuse midline glioma, histone 3K27M mutant. This is the actually official diagnosis. This was updated. This came out after 2010, but updated in the WHO classification in 2016. So this is a infiltrative high-grade glioma, including like glioblastoma or anaplastic astrocytoma, which has a novel mutation of this histone mutations. Can be different histone 1 mutations, but majority is histone 3. This is grade 4, and the median age at diagnosis is about 5 to 11, which is devastating because until this age group, patients are completely normal. And then male to female ratios are equal, commonly seen in brainstem, thalamus, and spinal cord as well. And then that includes the diffuse intrinsic pontine glioma that I just mentioned. So looking back, the DIPG patient, 80% of this PONS in DIPG patient carries these mutations. We thought the reason why these patients are having this small outcome is that because we cannot take out the tumor completely. However, there will be something else caused by the histone mutations, and we have not figured out how this is contributing to the worse prognosis. Okay. So these patients receiving radiation, and often patient goes to clinical trials, and we have over 200 clinical trials are tried on these populations, and none of them are making significant difference yet. So this is definitely a challenging populations. So another unique tumor in pediatrics is central tumors. We call it supratentorial pituitary is right here, or hypothalamic chiasmatic tumor. So this goes to the optic nerves as well. And this will obstruct the third ventricles. So this will be presenting with increased intracranial pressure. And then obviously abnormal eye movement or vision changes are very common. Other specifics is that related to the hormones. So diabetes insipidus can be the first sign of a tumor, which is usually two tumors that I'll mention later. Some seizures can be seen. And then I will also mention about the developmental delay a little bit later, and weight loss as well. Okay, so this is an 11-year-old female presented with the morning MSS and the lethargy. You see obviously on CT scan that the hydrocephalus, and then central, there is something in the middle that blocking the third ventricles. And then MRI showed these expansive tumors. So this is a pilocytic astrocytoma as well. This patient is currently receiving the chemotherapy. And another patient, this is a 4-year-old female with neurofibromatosis 1. She had a 3-month history of headache, nausea, vomiting, and then acutely lost the visions. So this patient had a huge supratentorial tumor affecting the chiasms. So she's actually permanently blind. And then she received chemotherapy, but the blindness did not come back. So this is a subtotal resection because they are afraid of structures around here. There are a lot of vessels and nerves. So this subtotal resection and treated with chemotherapy. So I showed you that neurofibromatosis genes affect this last laugh act mTOR pathways. These are all cancer related pathways. So the BRAF is here, the BRAF, and that is found, I mentioned earlier that it's found in about 60% of low-grade tumors. So the neurofibromatosis is part of this pathway causing this cell growth. So the newest treatment for neurofibromatosis with brain tumor will potentially become the targeted therapy. We were currently doing clinical trials with that. So for brain tumor surveillance for NF1 patients, there is actually controversies and recommendations published in 2007, and we're following this guidance. So patients with NF1 can develop brain tumors such as low-grade gliomas or optic pathway gliomas or both. And then all children with NF1 younger than 8 years old will receive eye exams, and then preferably by ophthalmologist or neuro-ophthalmologist, because younger age groups, it's difficult to evaluate the visions because we cannot do the cooperative exam, so we need a specialist to look at these. If it's not possible, then we will do the MRIs for surveillance. And then interestingly, NF1 patients' brain tumors worsens before age 8. So we need to definitely catch this group of the patients and then do the surveillance. And then above 8, we can loosen up the surveillance a little bit. They need to watch for the height and weight to look for the precocious puberty, because this hypothalamic region's tumor can cause these precocious puberties. There is no sufficient recommendations less than the 1 year old because of obviously we cannot get the cooperative vision exams. So we sometimes do the MRI as well. So once tumor is found, we were following every 3 monthly scans, and then tumor can be observed if there is no vision abnormalities. So we work with ophthalmology closely. So not many patients, but there are supratentorial tumors, especially less than the young age group and adolescent, that we need to keep an eye on these lesions as well. The common symptoms are unspecified increased ICP symptoms and seizures, and the more focal neurological signs. And the young age group, don't forget about the macrocephaly as well. So this is, I got actually consult yesterday that this is a patient 12 months old with macrocephaly symptoms, that this patient was appropriately referred to neurology, and then neurologist did the MRI and they found this huge tumor. And then patients are slightly delayed development, but apparently not that concerned from it. However, this tumor is huge, and then this will be operated in a couple of days. The most highest differentials is desmoplastic infantile ganglioglioma. This is, I see probably 1 case per year, but this is a benign tumor, and it can be, all of them can be removed, and the patient can be very well with minimum neurological deficit from the surgery. So this needs to be definitely treated. Other patient, 6 years old with acute onset of left side weakness. This is a healthy boy, suddenly at school, fall down and couldn't get up. This is a thalamic tumor, and this is histone mutated diffuse midline gliomas. It's also called glioblastoma in older diagnosis. This tumor was taken out completely. However, and they received radiation and chemotherapy. However, patient deceased about a year and couple of months later. So lastly, spinal cord tumors. The most common symptoms is back pain. And then I think Iowa had a strength in the chiropractors. So these patients, when they come to us, they often are seeing chiropractors. But I have to say, like, back pain in children needs to be paid more different approach than adults with back pains, and it needs definitely a scans. Other common, if there is abnormal gait or coordination difficulties, they are referred to us more quicker than that. But if just a simple back pains, it tends to be delayed to come to us. And then spinal deformities, scoliosis definitely needs to be evaluated, and then good neuro exams. And again, head tilt here as well. So this is a 15 years old with actually a school surveillance picked up the scoliosis and they found to have kind of a skipping tumors, and then it intramedullary spinal cord tumors, and then that was diagnosed as pilocytic astrocytoma. This is completely resected. He received the radiation and he's doing well after that. So a couple of pediatric specific symptoms that I want you guys to not to forget. One of them is diencephalic syndromes. So as I said, one of the common locations of the tumor in children is this central regions where it involves in diencephalic pathways, including the thalamus and the medial forebrain bundles to the pituitary. So this location's tumor can present with severe emaciation, frequently MSS, but normal linear growth. So patients are not actually sick looking, but frequently vomiting. So they are often worked up with for the failure to thrive. So when your patient doesn't have any organic reasons of failure to thrive, the MRI of the brain is a necessity. So these patients are usually normal or precocious intellectual, or like a development is normal, so it's kind of deceiving. And then they're also happy and euphoria, so they're eating a lot and then happy and not sick looking, but vomiting a lot. So that's why they don't gain weight. Their median age diagnosis is about 18 months, which is challenging because they often vomit anyway, but it ranges from 4 to 56 months. And then this is the striking part, is that usually pediatricians takes care of it and median of about 12 months. So if you have an extended period of time that managing the failure to thrive, please do the MRI brain or consult us. So this is an example of the patient. The patient started to probably have problems already around here, and then definitely the fell off the growth curves and then has the tumor. But as you can see, patients are actually happy and then very active. So other symptoms are this Parinode syndrome. This is also called the sunset eyes. Patient had trouble looking up, so you will see more white on the top part of the eyes. This is the tectum compression syndromes. And then this can be dilated pupils, and it can have a nystagmus. Usually a tumor is around here. This tumor cannot be resected completely without the neurological deficit, so we need to find what it is with biopsy and treat accordingly. They are usually young age, less than 1 year old. Other specific syndromes are endocrinopathies. Diabetes insipidus, when they develop centrally, and then brain tumor is the reason. There are only 2 brain tumors that does that, which is LCH, Langerhans cell hemophagocytosis. This is not really a brain tumor. This is actually systemic disease, but it will have punched regions in the skull, and then some activities in the pituitary regions, and it causes diabetes insipidus. Other tumor is germ cell tumors. Delayed growth or precocious puberty or developmental regression can be seen. And then prolactinoma, which causes breast milk. So this is abnormal in pediatric populations. So lastly, I'm gonna touch with emergency cases. Definitely increased ICP, increased intracranial pressure signs. The pressures are usually 7 to 15, and then patients can come in like 30s, 40s, which we can tell from the look. We have to do the lumbar puncture to know that, but the high pressure symptoms include headache, and usually more for towards the end of the course, early mornings. Vomiting without nausea is high alert, and ocular pulses, altered level of consciousness, back pain, and papilledema. And the Cushing triad, you would definitely send the case to ER, is increased systolic blood pressure, widened pulse, bradycardia, and then abnormal respiratory patterns. Personality and behavioral change also noticed often by parents. Sometimes the pilocytic astrocytoma or benign tumors causing increased cranial pressures, changes can be years. So I have recently a patient who, going back to 2 years, that his cognitive function started to decline, but so subtle, the changes is so subtle that they thought that there was just him. And then unfortunately, he had a prolonged period of hydrocephalus over 2 years. So these cases, you can use actually dexamethasone. So that is the rescue. But I think that sending to the ER is the best place. Spinal cord compression is another emergencies. And usually they have a neurological deficit. And then this is also okay to use steroid. And then acute vision changes. So this, usually the brain tumors vision changes are gradual. So not like a sudden onset unless they had a stroke or something like that event. And then usually one eye more than the other because it's a localized symptoms, so that the other eye actually compensate. So it's hard to detect the acute vision change in pediatric brain tumor patient. But if it happened, it can be a leukemia disease. And then those cases, steroid is not, we don't want you to use a steroid, so it's a little bit challenging, but we need definitely ophthalmology look up, and then we sometimes do emergent radiation for these cases, and the vision can be salvaged if it's acute cases. So I would just summarize here. I talked about the pediatric brain tumor is different from adult brain tumors. They have more varieties, and then treatment is different by ages, so that radiation cannot be used for younger age groups. We'd like to delay as much as possible, but the certain malignancies that radiation is necessary in the treatment. Some tumors are benign, but based on the locations, it can be needing the cytotoxic or cancer therapies, basically. It is difficult for family to understand that, but we treat like a cancer, basically. And then there are some inheritable tumors because of pediatric population, obviously. And then treatment challenges, I'm sorry, Corey, this is a change. Treatment change will start to happen. It's already happening. More targeted therapies will come to the field. And then there are more and more agents that we started to use, not only BRAF, but the other mutations. So that will change the treatment of landscape of treatment in brain tumors. We have to pay attention to the late effect, because our goal is to cure patients and then they will live longer and they have children. So the late effect includes cognitive effect, endocrine effect, and then secondary malignancies. So, and then I spend a lot of time talking about the location and symptoms of the brain and spine tumors and emergencies. Patients often have non-specific symptoms: headache, is very common, even children's. And then nausea, vomiting is also common. So I can't, it is difficult for you guys to find the brain tumors with those non-specific symptoms, but it can, and then the symptoms, it wax and wanes, and then, however, if it is persisting and it's getting more worsening, that is something to pay attention. And then other diseases are ruled out and it's still causing the symptoms, then we're happy to see. And then look for the signs pointing at the brain or spine tumor, some kind of a neurological deficit, even subtle, that would be helpful to point out to the appropriately workups. If you suspect brain or spine tumor, do not hesitate to call someone. And then we are happy to see the rule out patients. Patients don't have to cancer, and that's the best outcome. But you guys can call us if you suspect. We're happy to see. So please consider referral to, for example, ophthalmology, because I mentioned retina is the window of the brain. So if we have suspect of prolonged headache or nausea, vomiting, we can look it up, the papillary edema. If it's not, we don't have to do emergently anything. If you suspect increase, and then other visual signs like nystagmus or squint or deviations, those needs to be seen by, and head tilt, those needs to be seen by ophthalmology. And then please call neurosurgery for emergencies. They are very quick and see them right away in the ERs. Also send the kids with increased head circumferences. Neurology for seizure or these signs as well. And I'm happy to see those patients anytime. And then the one thing that I want to emphasize, that when you think that you put appropriate consult, please follow up, or please see that at the timing of the appointment. Because we've seen that the neurology was consulted, but it was 2 months away, and then sometimes that was too long. And then when you guys order MRI, often they were not urgently taken care by, and the insurance can be challenging. And when we order MRI, we have a way to get it done in the day. And then if patients are in ER, we can do that immediately, definitely. So if you suspect brain tumors and then need imaging, but you don't know what to do, just call us. We can help you out. And then I think insurance should not dictate our patients' conditions. So we need to address appropriately some of the referrals. So I think that's all I have. Thank you very much for listening and coming this morning. And I will take questions.
If you do have a question, you can type it into the chat function. You can also unmute yourself and ask directly as well.
And here is my contact. Please feel free to contact me as well.
We did record this, so we'll be sending it out to everyone. We will also send you the information for your physician liaison.
Okay.
We are here to connect you with any of the physicians at the University of Iowa hospitals and clinics, including Dr. Sato. So that includes questions that you might have even later on, or specific patients you want to discuss or refer. We can help you with that process as well. All right.
Thank you very much. I hope you get something from this. And then, I shouldn't say I hope to talk to you about the patient, but we're happy to help here. So thank you very much.
All right. Actually, it looks like we do have a question.
Okay. Yeah, go ahead.
What determines stem cell rescue or radiation treatment for medulloblastoma?
The treatment. So the stem cell rescue is it's called the high dose chemotherapy with stem cell rescue. It's the word that we can give the highest dose of chemotherapy possible, but that basically wipe away the bone marrow. So when we do chemotherapy, usually we don't wipe away bone marrow. So patient decrease the blood counts and then come back up. But this therapy is so severe that they don't come back. So brain tumor often use this approach when patients are too young and they cannot get the radiations as adjuvant therapy. And it's been successful. So patients definitely less than 3 years old of medulloblastoma will get high dose chemotherapy with stem cell rescue. ATRT can get the dose therapy as well. And then second part is that radiation. So as young as actually 1 year old, we do focal radiation for ependymoma patient. And that was because ependymoma is known to have no responsiveness to chemotherapy. So radiation is the only good treatment, but those are focal. So the craniospinal radiation is different. That is like whole brain and whole spine get radiation, which is used for malignancies, which is medulloblastoma, ATRT, and a little bit of germ cell tumors. Germ cell tumors are usually adolescent, so cognitive effect is a little bit, preserved. Still would like to avoid that, to avoid that secondary malignancies and hormone problems. But medulloblastoma, which is mostly a young kid's disease, and the ATRT, those are the two major ones. And then there is another embryonal tumors. It comes in the supratentorial area that also needs a radiation. And sometimes it's a big field of radiation that affect the cognitive abilities. So, however, we have to save the lives. So we don't have any alternative treatment. So we are still radiating, but the University of Iowa is participating into that national studies, which is we are raising the age of the radiation as many as 8 years old on the medulloblastoma patient. So if patients are between 3 to 8, we can enroll this patient to this protocol, which include the high dose chemo with stem cell rescue, but eliminate the radiations. So that's how we were studying to see if we can make same we can save the same number of patients with that approach. Because this is still challenging because we don't have any salvage therapies if tumor comes back. Thank you for the questions.
Thank you for the answer. All right, last call for any other questions.
So we were just talking with Randy, but University of Iowa is lumping up the outpatient, and the hematology oncology actually did not decrease much other than on the active therapy patients. And then we are operating normally, as you guys are probably coming back to work as well. So stay safe, and then it was nice connecting you guys.
All right. Well, thank you, Dr. Sato, and thank you everyone for attending today's presentation on pediatric brain and spine tumors. We will be sending you the presentation and follow-up communication So thank you. And like she said, be safe and have a great weekend.